Crohn's disease and ulcerative colitis both are collectively considered as inflammatory bowel disease. Compared to the ulcerative colitis, Crohn's disease may affect any part of the GI tract. But as name suggests, ulcerative colitis only affects the colon. Even there are some more differences between these two, we are not going to discuss it here. There is a degree of overlap between these two conditions in their clinical features, histological and radiological abnormalities. It is clinically useful to distinguish between these two conditions because of differences in their management, although in reality they may represent two aspects of the same disease. Epidemiology. Both conditions have a worldwide distribution, while the highest incidence rates and prevalence have been reported from Northern Europe, the UK and North America. Pathology. Inflammatory bowel disease occurs when the mucosal immune system exerts an inappropriate response to luminal antigens, such as bacteria, which may enter the mucosa via a leaky epithelium. Recent research has highlighted deficiencies in the clearance of invading bacteria by aspects of the innate immune system, such as neutrophils, may allow inappropriate activation of the acquired immune system, leading to gastrointestinal mucosal damage. Crohn's disease is a chronic inflammatory condition that may affect any part of the gastrointestinal tract from the mouth to the anus, but has a particular tendency to affect the terminal ileum and descending colon. The disease can involve one small area of the gut, such as the terminal ileum, or multiple areas with relatively normal bowel in between, also called as skip lesions. It may also involve the whole of the colon, sometimes without macroscopic small bowel involvement. In Crohn's disease, the involved bowel is usually thickened and often narrowed. Deep ulcers and fissures in the mucosa produce a cobblestone appearance. In penetrating disease, fistulae and abscesses can be seen. Aphthoid ulceration is an early feature, usually seen at colonoscopy. Later, larger and deeper ulcers appear in a patchy distribution, again producing a cobblestone appearance. In Crohn's disease, the inflammation extends through all layers of the bowel, also called as transmural, whereas in ulcerative colitis, there is only superficial inflammation, as well as in Crohn's disease, increased chronic inflammatory cells and lymphoid hyperplasia, and in 50–60% of patients granulomas are present. These granulomas are non-caseating epithelioid cell aggregates with Langerhans giant cells. Diarrhea, abdominal pain and weight loss are the major symptoms of Crohn's disease. Constitutional symptoms like malaise, lethargy, anorexia, nausea, vomiting and low-grade fever may be present, and some patients may not have any gastrointestinal symptoms. Crohn's disease can be complicated by anal and perineal disease, and this is the presenting feature in 1/4 of cases, often preceding colonic and small intestinal symptoms. Enteric fistulae with bladder, vagina or abdominal wall will occur in 20–40% of cases. There's currently no cure for Crohn's disease, but treatment can control or reduce the symptoms and help stop them coming back. Medicines are the main treatments, but sometimes surgery may be needed. No single treatment works for everyone with Crohn's disease. The goals of treatment are to decrease the inflammation in intestines, to prevent flare-ups of symptoms, and remission. Aminosalicylates contain 5-aminosalicylic acid, 5-ASA, which helps control inflammation. Aminosalicylates are used to treat people newly diagnosed with Crohn's disease who have mild symptoms. Aminosalicylates include balsalazide, mesalamine, ulsalazine, sulfasalazine. Corticosteroids, also known as steroids, help reduce the activity of immune system and decrease inflammation. Corticosteroids are used to treat patient who is having moderate to severe symptoms. Some commonly used corticosteroids are budesonide, hydrocortisone, methylprednisolone, prednisone. Immunomodulators reduce immune system activity, resulting in less inflammation in digestive tract. Immunomodulators can take several weeks to 3 months to start working. Immunomodulators include mercaptopurine, azathioprine, cyclosporine, methotrexate. Biologic therapies target proteins made by the immune system. Neutralizing these proteins decreases inflammation in the intestines. Biologic therapies are used for remission, especially if patients do not respond to other medicines. Biologic therapies include anti-tumor necrosis factor alpha therapies, such as adalimumab, certolizumab, and infliximab. Thank you for watching. Ulcerative colitis may be discussed in a new video. Hope you enjoyed the video.